Hello everyone, my group and I will be doing a presentation on cardiac chest pain as a result of acute coronary syndrome. This concept map shows cardiac chest pain as a resultant of acute coronary syndrome, or ACS. Acute myocardial infarction comes under ACS and will be the main point of discussion in this presentation. The pathophysiology behind acute MI and how it leads to cardiac chest pain will be further discussed in the next slide. This concept map shows the link between the pathophysiology and how it results in various signs and symptoms. Risk factors, diagnostic tests, management, and complications are also briefly illustrated in this map.
Hi, this is Avneet. So I'm presenting you the pathophysiology of acute coronary syndrome. Acute coronary syndrome is a condition that obstructs coronary arteries and reduces the flow of blood to the heart. It includes acute myocardial infarction. This causes sudden cardiac death, and this is also the cause of cardiac chest pain. Acute myocardial infarction, also described as myocardial necrosis, is described as a sudden ischemic death of the myocardial tissue. The underlying pathophysiology is the coronary occlusion caused due to the rupture of plaque within an epicardial coronary artery. So this rupture of the plaque then exposes the inner lining of the artery to the blood. When it exposes the inner lining of the artery to the blood, the platelets aggregate and this leads to the formation of thrombus, and this also causes vasodilation of the coronary artery. The vasodilation causes the artery lumen of the artery decreases and it thickens the artery and thus reduces the blood flow, and this process is also called as atherosclerosis. And the platelet aggregation, which leads to the thrombus formation, blocks the supply of blood to the myocardium tissue. So when the myocardium tissue of the heart is deprived of the oxygen-rich blood, it creates a necrotic area. That necrotic area stops contracting, and when it stops contracting, this causes a chest pain that radiates from the left to the right arm. So this is the pathophysiology of why and how myocardial infarction causes the chest pain from the left to the right arm. Thank you.
Thank you, Avanich. I will talk about the risk factors and signs and symptoms of coronary artery disease. There are two major types of risk factors: non-modifiable risk factors and modifiable risk factors. For example, age is non-modifiable risk factor. For men being 45 years or older and women being 55 years or older would have the higher risk bracket than being younger than that. Since this group people are more prone to developing plaques, then plaque forming will lead to atherosclerosis, then become coronary artery disease. Family history is another example of non-modifiable risk factor. Coronary heart disease has a lot of genetic influence to its development. For modifiable risk factors, there are quite a lot of things we can do to prevent people from developing atherosclerosis or plaques. For example, high blood cholesterol level, especially LDL, is a huge part of development of atheroma. These plaques are built up of cholesterol in the wall and damages the wall of blood vessels. If people have high level of LDL in their blood, the level of triglycerides will be high. Then high level of certain types of fat will increase the level of other enzymes that increase plaque formation. High blood pressure will damage the blood vessel wall with shear stress. Also, smoking damages the blood vessel wall. When the blood vessel wall has been damaged, the cholesterol will jump in and build a huge plaque and will develop atherosclerosis. Next one is diabetics. Excess glucose floating around unregulated in blood. They make the blood vessel stiff and damaged, which will cause glycosylation, then set up coronary artery disease and plaque formation. For people who have obesity, lack of physical activity, increasing the level of physical activity can dramatically reduce the risk of developing coronary artery disease. When people do exercise, can improve the level of glucose in the blood, improve the cholesterol profile, use up a lot of fats, can lower blood pressure. Also, not enough intake of fruit and vegetables is one of the modifiable risk factors as well. For signs and symptoms, some patients have no signs and symptoms, but if put them in exercise or stress test, the patient might manifest lack of oxygen supply to the heart. When some patients are doing some runnings, climbing stairs, they experience chest pain, pressure, or tightness in the chest, breathing difficulty, tachycardia, fatigue, anxiety, nausea, and vomiting. The pain can be in the center of the chest or the left side of the chest. It can go up to the neck, to the jaw, to the shoulder, to the arm, more commonly left arm than right arm. With rest, the symptoms will be relieved or disappear. With activity, it may come back. That's all for me. Thank you.
Hi everyone, my name is Darshini Wangoda. I'm presenting diagnostic test and clinical management. Under diagnostic test, 12 leads electrocardiogram or ECG, check ST elevation or non-ST elevation. ST elevation is myocardial infarct or non-ST elevation is myocardial infarctions. Another test is coronary angiography. Coronary angiography used to check any blockages on the coronary artery. Cardiologists or doctors who specialized in the heart will perform coronary angiography in hospital or specialized laboratory. That will help doctors to plan the patient treatment as well. Chest X-ray, by doing this, can measure size of the heart and blood vessels, fluid in the lungs, like that. And echocardiogram is check how heart chambers and vessels are pumping blood through the heart, um, and it's use um, electrodes to check heart rhythm and ultrasound technology to see how heart move through the how blood move through the heart. Um, this is performed by the doctor or specialized person. Another test is blood test. It's called serum cardiac markers. By doing this, biomarkers measured to evaluate heart functions. Another important thing is patient history, because if if someone has high potentials or diabetics, more likely to have chest pain or heart problems.
Next is clinical management. When a patient comes in with cardiac chest pain, a PQRST assessment is used to determine the provoking factors, quality, radiation, severity, and time of onset of the pain. Management as nurses is to continue monitoring vital signs. Oxygen therapy can be initiated via nasal prongs to help keep oxygen saturations above 93%. This is important to preserve as much cardiac tissue as possible. We would perform a 12-lead ECG and continuous heart monitoring. The ECG reading may change to reflect the infarction process, which will be useful for tracking the extent of damage and escalate when things get worse. Pain relief is given to manage the cardiac chest pain. Nurses can administer 300 to 600 grams of sublingual glyceryl trinitrate, or GTN, to help relieve the pain. It helps to calm the patient and reduce the oxygen demands. GTN causes a systemic vasodilation, which can result in hypotension. Therefore, patients' blood pressure should be closely monitored. A further 300 to 600 grams of GTN can be administered if the pain is not relieved after 5 minutes. A follow-up 12-lead ECG will need to be done, and the doctor should also be contacted for a clinical review. A doctor may also establish an IV access for emergency drug therapies. Now, a percutaneous cardiac intervention, or PCI, is usually the first line of treatment for patients with MI. The goal is to open up the blocked arteries within 60 minutes of arrival. The procedure involves the catheter being threaded into the blocked arteries of the heart to release a stent or balloon that will help open up the narrow blood vessels. A thrombolytic therapy is also done. It aims to stop the infarction process by dissolving the thrombus in the coronary arteries and provide perfusion to the heart. All thrombolytics are given IV.
Here are the summaries of the major types commonly prescribed cardiovascular drugs. Firstly, opioid analgesic. It is a standard therapy for pain management that is used by most of the physicians. In the recent report produced as part of the review on the result of usage of morphine is beneficial in the setting of acute heart failure. Morphine could release severe chest pain and breathlessness, especially it is fast-acting if administered through intravenously. Secondly, blood thinner, anticoagulant and antiplatelet drugs. Anticoagulants such as heparin or warfarin, it is to slow down your body process of making clot. Antiplatelet drugs such as aspirin prevent blood cells called platelet from clumping together to form a clot. The glycoprotein 2B3A inhibitors are the agent of the antiplatelet, which are frequently used during percutaneous coronary intervention. They work by preventing platelet aggregation and intracoronary thrombosis. They do so by inhibition of the glycoprotein 2B3A receptor on the surface of the platelet. Next, the antihypertension. In general, there are five major agents, which are calcium channel blocker, angiotensin receptor blocker, angiotensin converting enzyme, inhibitor, and diuretic. Every agent works differently to lower high blood pressure. The drug should be selected considering the comorbid conditions, contraindications that require the careful use of drugs, and the presence or absence of complications. Sometimes the combination therapy with different classes of antihypertensive drugs display potent hypotensive effect, and it useful for achieving the target of blood pressure control. diuretic such as hydrocortisone, also an antihypertension agent, to help voids acid, salt, and water by blocking the reabsorption of sodium and water in order to decreasing the amount of fluid flowing through your veins and arteries. This actually could reduce blood pressure. However, the usage may result in potassium deficiency. Therefore, potassium supplementation is required as a compensation. Other types of diuretic that can use to treat hypertension include potassium-sparing diuretic such as amyloid, which produce a weak diuresis without affecting potassium excretion. Come to statin and lipido. Statin is an agent to control the LDL, bad cholesterol under 100 mg per deciliter to prevent second heart attack. Evidently, early use of statins as a treatment to lower cholesterol in patients with acute coronary syndrome is generally safe, even when considering the highest approved doses of potent statin. In terms of efficacy, early statin therapy seems to reduce the risk of unstable angina at 4 months after an acute coronary syndrome. Nitro is the vasodilators. Basically, it helps to widen the blood vessel, smoothen blood flow, and allow oxygenated blood to reach the heart. It also reduces heavy workload on the heart by relaxing tight veins and decreasing the amount of blood returning to the heart.
Moving on to complications. The most common one is arrhythmia, which is present in 80 to 90% of patients. Necrosis in an area of the heart disrupts the electrical conduction system. For example, necrosis in the right atrium area will cause arrhythmia due to the damage of the two major pacemakers of the heart, SA node and the AV node. Ventricular fibrillation is a life-threatening arrhythmia that often occurs within 4 hours after the onset of pain. Next is cardiogenic shock. MI causes a reduced heart contractility. Therefore, it can't effectively push blood out of the left ventricle to the rest of the body, especially to vital organs like the brain, kidneys, and heart. This can result in hypotension and a low cardiac output. This condition is described as cardiogenic shock. Heart failure is when part of the heart muscles are destroyed, causing the heart to not pump blood as efficiently. Long-term complications include papillary muscle rupture. These are the muscles that keep the valves closed during ventricular filling to prevent the backflow of blood. For example, if the infarction causes rupture of the papillary muscles controlling the mitral valve, it won't close properly and some blood will regurgitate back into the left atrium. This results in a condition called mitral regurgitation. Next is pericarditis, which is often occurring within 2 to 3 days after an acute MI. It is the inflammation of pericardium, which is the outer fibrous covering of the heart. MI triggers an immune response, which will cause platelet aggregation. This can irritate the pericardium and result in pericarditis. The force of contraction of the heart is reduced, thus, there is a decrease in ventricular filling and emptying, and can result in heart failure. Ventricular septal defect is a necrosis of the septum that separates the left and right sides of the heart. Oxygenated blood in the left side and the deoxygenated blood in the right side will mix and would cause hypoxemia because there is not enough oxygen circulating in the blood. Ventricular aneurysm is the bulging of the infarcted myocardial wall during contraction. This develops within a few days, weeks, or months. Infarcted myocardial wall is thin, so blood can actually rupture the ventricle during contraction, and blood can burst out of the heart. This is known as ventricular rupture, and it is fatal. Ventricular aneurysms can harbor thrombi that can break off and become an embolus and cause an obstruction somewhere else in the body. If it goes to the brain, it will cause an embolytic stroke. After an MI, if you develop a decreased heart contractility, a mitral regurgitation, or a ventricular septal defect, you are at great risk of developing congestive heart failure, which is when your heart can't pump enough blood to meet the oxygen demands of the body, and so will have to work harder to maintain proper perfusion of your body with blood. These are the references consulted for the presentation. Thank you for listening and have a great day.